So hello everybody, it's my pleasure to be invited back this year to the ALD Alliance meeting. I run the bone marrow transplant program at the Children's Hospital of Philadelphia, 90 minutes or so to the southwest of here. And I think I can piggyback on Rich's talk quite well because I can give you the clinician's perspective as to how we're interpreting a lot of the data, both the positives and the negatives that have come out of the gene therapy trials and how we're incorporating this into our practice. And I think I have a unique perspective on these challenges based on what my career history has been, which is the longest standing role that I've had over the last 2 decades is I manage the patients in our hospital who have disorders called bone marrow failure syndromes. And these are the syndromes that Rich was talking about that have a lifelong risk of developing MDS and leukemia. So for a long time, I've been thinking about surveillance for those conditions. The other thing that I've been involved in is, though we were not trial sites for ALD 102 or ALD 104, our center has been instrumental in the development of gene therapies for other conditions, sickle cell disease and thalassemia in particular. And so I have that background as well. And then I'll just say that while sites such as Boston and Minnesota and some across the world were working on the ALD 102 and 104 trials, we have a very large leukodystrophy program at CHOP, and we have been doing allogeneic transplants for patients with leukodystrophy, and so I can tell you some of the improvements and some of the drawbacks with that approach as well. So, I think the best way to sum this up, and I'll skip through the beginning of this fairly quickly because it overlaps with some of what Rich was saying, but I think the biggest paradigm shift for those of us who do curative stem cell therapies really since the inception of the field has come in the last 5 years with the FDA approval of 5 different products now that are autologous stem cell based gene therapies for patients. And for ALD, this comes on the back of the studies, and this is data from ALD 102, which Rich touched on, which shows excellent overall survival and excellent major functional disability free survival in patients who have received Skysona. And so I don't think you could have gotten a higher high for those of us who do stem cell curative therapies than we've had in the last few years, knowing that we have these new options available that are FDA approved. Unfortunately, sometimes when you hit a high, there's a low that comes after this. And so as Rich just presented, and I'll touch on as well, the specter of MDS and leukemia risk in patients who have been through Skysona is incredibly troubling to us. And so how do we incorporate this information and how we advise patients to move forward with therapies? Rich touched on this, but I'm just presenting it in a little bit of a different way. So if you look at the number of cases that have happened, 2 out of 32 patients, or 6% of the patients that are on ALD 102, have developed MDS, and then 8 out of the 35 patients on ALD 104 have developed either MDS or leukemia. And so if you look at all of the patients that are on the clinical trials, that equates to about 15% of the patients who have been through gene therapy on the clinical trials. Now, I don't have these numbers exactly correct, so don't quote me on this too much, but I think there's somewhere between 8 to 10 patients who have received commercial gene therapy after the approval of Skysona, and most of these have received approved Skysona therapy. There are a couple of cases where products after manufacture didn't meet all of the benchmarks for release, and so we've thought that these products were safe and needed to give them on a research basis as well. But to my knowledge, with about up to 1 to 2 years of follow-up, there have not been reported cases of MDS or leukemia for those patients. So as Rich already said, it's clear that the driving factor of the MDS AML cases in patients who receive Skysona is the vector. And we know this because there are characteristic ways that the vector has integrated into the stem cells DNA, and these integrations related to the MECOM and the PRDM16 genes seem to be the most common in patients who go on to develop MDS or AML. you can actually track as platelets start to fall as a harbinger of MDS and AML, that you see increased integration site frequency, and you can see increase in the vector copy number, so you know it's related to where the DNA has been manipulated. As Rich pointed out, 8 of the 10 cases have occurred on the ALD 104 study, and these are occurring at earlier time points than the 2 cases that have occurred on the ALD 102 study. There is not a lot of consistency, although there are some recurrent themes in the acquired variants that happen in the leukemia clone. There seem to be a couple of patterns. There are genes called RAS genes, which are involved in cell proliferation, which seem to be additional acquired hits that happen. Monosomy 7, which, in wearing my other hat and taking care of those bone marrow failure syndromes, that's the most common path to MDS in children, is when you develop monosomy 7 and RUNX1 mutations and PTPN11 mutations as well. And then we just talked about most, but not all of these patients have been successfully retransplanted. So what do we do from here, right? This is obviously an imperfect therapy, right? We want to be able to give a gene therapy that does not have a risk of MDS or AML. We know that this is related to the vector, and we know the reason for it, in all likelihood, is that the promoter that is used in this vector is different than any of the promoters that are used in any of the other gene therapies as well. And there was a strong rationale for doing it at the time that this was designed. It was uncertain which cell type you had to fix in the bone marrow to lead to an effective therapy. And so they went for as broad of a expression pattern as possible. So if we know the problem is the vector, can't we just use a new one, right? Can't we just come up with a new one? Well, there are a few problems with that, right? Number one is, think about how long this has taken to get to an FDA approval. It took about a decade from the opening of the first trial. So it would take a long time to wait for that new therapy, right? Number two is, you're going to need to have an industry partner that's going to be willing and able to invest in this. And there are unfortunately a few headwinds against that being likely right now. Number one is, in general, I think there has been a sobering reality across the stem cell gene therapy field about the financial pros and cons of developing gene therapies for rare diseases. And so I think there are a lot of companies that are a little bit gun shy to get into that field. So that's one challenge. I think the other challenge is, quite frankly, if you're one of those companies who would be willing to try it, are you going to be afraid of doing this in ALD because of this history of having a gene therapy where there has been an MDS leukemia risk? So I'm not saying it won't happen, but I think that's a barrier to developing a new gene therapy as well. And then the third barrier goes back to the original point of why this approach was chosen, which is we still aren't 100% sure in what cells you need to correct the gene to get the therapeutic effectiveness of preventing the neurologic progression as well. And so there's a risk that if you change the vector significantly, it might impact efficacy too. So if we can't fix the vector, is there anything else that we can do to modify this MDS or leukemia risk, right? And Rich touched on this a little bit, and I'll take it from here, and I'm happy to have a dialogue with everyone about my thoughts on this. But I think the key clue here is maybe there are things that we can do, and one of the things that we can do is focus on why is this MDS AML occurring earlier and more frequently in the patients that were treated on the ALD 104 study versus the 102 study. And there are a few differences in terms of ideas for what could be going on. Number one is the manufacturing process was a little bit different. Depending upon who you ask, that plays a greater or lesser role in this. But in terms of how the virus is introduced, the target for the number of copies of the gene might be a little bit different as well. I'll let people like Dr. Eichler and others who know this data a little bit more than I do get into that a bit more, but that's one possibility. One thing coming from that, wearing that hat of those MDS predisposition disorders that I do, is what I will tell you is we avoid at all costs using as a standard therapy the use of hematopoietic growth factors to push out and increase blood cells if you have patients who have diseases like Fanconi anemia and telomere diseases, because we know that those growth factors are going to promote the growth of pre-malignant cells more than they're going to promote the growth of healthy cells as well. And it is notable on ALD 104 that the use of GCSF in particular was standard for patients post-transplant on that study, and it wasn't standard in 102. So that's one potentially modifiable factor. And then the third one, which is what I spent all of my time last year talking about, is the differences in the conditioning between the two protocols as well. And so then you have to go back to the beginning of the study as to why the conditioning was chosen for the ALD studies, which makes it unique compared to all of the other approved gene therapies, which only use busulfan as conditioning. So sickle cell disease, thalassemia, metachromatic leukodystrophy, it's busulfan-only conditioning. There was a worry in that case, though, that we didn't really know how to best affect this neurologic progression in ALD. And the thought is combining it with immune ablation could be helpful for a number of reasons, one of which was directly reducing inflammation, helping with monocyte microglial depletion as well, and then resetting adaptive immunity that may have developed sort of a pathological cycle, if you will, as well. And so when these trials were designed, they decided to mirror the conditioning that had worked in allogeneic transplant. The first one, as Rich already mentioned, combined busulfan with cyclophosphamide in ALD 102, and the second one combined busulfan with fludarabine. And the rationale for switching to fludarabine made a lot of sense, and I think you might have mentioned this as well, because if you look at all of our data from doing other allogeneic transplants, fludarabine seems to be the safer drug versus cyclophosphamide. And in fact, cyclophosphamide belongs to a category of conditioning agents that are alkylating conditioning agents, and cyclophosphamide is notorious for being associated with the development of monosomy 7 MDS after treatment, and fludarabine is not. So the rationale for trying to switch makes sense. However, in the past decade since these trials started, we've learned a little bit more about some of the benefits of cyclophosphamide versus fludarabine, and in fact there was a trial in the Children's Oncology Group for patients with myeloid leukemia that actually demonstrated that cyclophosphamide might be a more effective conditioning regimen than fludarabine. And a few of the hypotheses behind this, there's preclinical data that suggests that cyclophosphamide is better at achieving immune modulation in the bone marrow microenvironment and suppressing inflammation than is fludarabine, which less completely eliminates T cells. So you might be setting up a less inflammatory bone marrow environment for the new cells from the gene therapy to come into. And we do know from a variety of diseases that the more inflamed the bone marrow is, the higher the risk of malignancy. So this is, again, a possibility to try to modulate the leukemia risk here. All right. Should we just give up on gene therapy and refocus on allogeneic transplant? And I think if you asked 20 different transplant physicians this question, I think you'd get 20 different answers as to whether or not we should do it, right? I'm going to give you my answer, but I want to be very clear that I don't necessarily represent the opinions of other folks who do transplants for leukodystrophy. It's possible we'll be forced to at some point, either based on industry decisions or based on FDA mandates. There may be a threshold above which this leukemia risk gets too high to be able to continue to offer this therapy. But I'm here to tell you we should remember why we wanted gene therapy so badly in the first place. And this gets to a slide that Rich also showed, that if you look at the outcomes of patients in terms of overall survival, and we as transplant physicians do a lot of funny things with survival curves. Sometimes they're event-free survival, sometimes they're disability-free survival, GVHD survival. This is overall survival. This means whether the patient is alive or dead, right? To be overly blunt, and I apologize for that. But If you look at patients who have matched donors who go to allogeneic transplant for leukodystrophy, they have overall survival that's very similar to patients who go to gene therapy. But once you get into situations where all you have is a mismatched donor, 20% of the patients who receive that therapy are dead by a year after the mismatched donor transplant. And that is a huge burden to think about. And so we really have to think about the MDS risk in the context of this. In terms of gene therapy outcomes, in terms of risk of death from the therapy, it's exceedingly low compared to a mismatched allogeneic transplant in particular. If you look across the clinical trial experience of all 5 of the FDA-approved gene therapies, the death rate that has been tagged as related to transplant is only about 2 to 3%, and most of that has occurred in the setting of older patients with sickle cell disease. In our experience of 36 patients, either on clinical trials or post-approval getting gene therapy at CHOP, we have not had any transplant-related deaths. And then transplant-related mortality in the first year of the ELICell studies is also 0%, right? So that 20% risk is entirely mitigated by going to gene therapy. Now, when you have a fully matched donor and the transplant-related death risk is low, I think it makes sense to use that donor if the other therapy has a leukemia risk, right? And so this is where we have deviated in the setting of ALD from what we are doing for sickle cell disease and thalassemia. In sickle cell disease and thalassemia, we have stopped altogether doing unrelated donor transplants, and we've moved just into gene therapy. But if you have a fully matched unrelated donor with adrenoleukodystrophy, given the leukemia risk with Skysona, we are preferring to do the 10 out of 10 unrelated donor. It's when you get into the mismatched donors and you assume that 20% risk of transplant-related mortality that this decision gets a heck of a lot more difficult. And unfortunately, this is a huge equity problem too, right? So if you practice in a transplant center somewhere where the vast majority of your patients are of Northern European descent, then you probably don't need gene therapy because you're likely to have a fully matched donor in the majority of your patients. If you practice in Philadelphia or New York, where we have a wonderfully diverse population from all over the world, most of our patients don't have fully matched donors. And so we're in the setting of having to decide which of these risks to want to choose. History of alternative donor transplant outcomes, they're getting better, and there are a lot of reasons why they have gotten better over time, right? We're better at matching donors. We've developed disease-specific conditioning and immune prophylaxis to prevent rejection. We have methods to try to prevent graft versus host disease, which I'll describe in a minute. And these have made remarkable changes and improvements in all types of transplants, and particularly fully matched unrelated donor transplants. But unfortunately, what we're seeing is despite all these improvements, the patients who have mismatched donors have plateaued at a level of overall survival that seems to be lower than those patients who have matched donors. Why is it more difficult? The Goldilocks effect really comes into play with mismatched unrelated donors. It's hard to get the strength of the regimen right. If you're too strong, you're going to run into organ toxicity, you're going to run into GVHD and problems with autoimmunity, autoimmune cytopenias. If you're too weak, you're going to run into graft rejection, poor immune recovery, and infections as well. So when I meet with families, I go over the relative pros and cons of both of the therapies. There are some things that favor doing mismatched unrelated donor transplants, right? The costs and access is a little bit better for mismatched unrelated donors. The time to treatment, you can go much more quickly. You don't have to wait to manufacture a product. Engraftment is rapid, and the MDS risk is low. But there are a whole bunch of things that still favor lentiviral gene therapy, even with this MDS risk, right? There's no GVHD risk. You don't have to give serotherapy or post-transplant immune suppression in the setting of gene therapy, so the infection risks is lower, medication burdens are lower, you don't have to worry about graft failure in nearly the same way, and the transplant-related mortality risk is lower too. We have done a number of things to try to get better at mismatched unrelated donor transplants, right? 15 years ago, people were using unmanipulated transplants, and that's something that we don't usually use anymore. We'll still use unmanipulated cord blood in some situations, but if you have mismatched cord blood, there's risks of GVHD and graft rejection in those situations. If we only have haploidentical donors or if we have mismatched donors, we're now moving to methods such as post-transplant cyclophosphamide, or what we use in our center, which is we can engineer the graft using a magnetic device to eliminate the risk of giving alpha-beta T cells which contain the T cell fractions that cause GVHD. So we can greatly reduce the risk of GVHD now, and we can modulate that a lot. But that comes at the cost of declawing the graft a little bit, and you run into problems with infections and graft rejection and a few other immune phenomenon as well. And so I just want to end with a sobering case, which while MDS, I'm not downplaying that risk at all. That's a very serious risk. Sometimes when you have mismatched unrelated donor transplants, it goes awry, and we don't have an explanation as to why. And so this is an example from several years ago, and I've made the details vague to not be able to link to anybody you may or may not know. But 5-year-old boy, X-linked ALD, undergoes a mismatched donor transplant. We use the optimized conditioning regimen that's been established at Minnesota and other places. You have a T-cell depleted graft to prevent graft versus host disease. You use post-transplant immune suppression, which is relatively non-toxic, to try to prevent graft rejection. Patient does great and grafts neutrophils and grafts platelets very quickly. No GVHD, no infections, no VOD. Patient is getting ready to go home from the hospital. And the day before they're going home from the hospital, all of a sudden they develop an oxygen requirement. They develop increased work of breathing, and within 2 days requires a breathing tube. We look everywhere for infections. We can't find an infection anywhere, right? We look for graft versus host disease. We see no signs of GVHD. We treat it empirically anyway, and we treat with antibiotics as well. And it doesn't get better. And unfortunately, within a few weeks, the patient passes away from what we would have to term as idiopathic pneumonia syndrome. This is not a diagnosis we see in gene therapy, right? This is a diagnosis we see in mismatched transplants, right? As long as we don't have an explanation for why this can happen in mismatched unrelated donor transplants, I see value in gene therapy, regardless of there being this risk in 15% of patients of developing leukemia. So what is my personal approach? How do I go about doing this, right? I have a family who comes to meet me. Their best option is a mismatched unrelated donor transplant, and we talk about the two options. I believe in shared decision-making. We're willing to offer both. We will talk about the pros and cons of both, and if I hear from the family one of two things, it might steer us in one direction. If cancer is the biggest fear on the minds of the family, that suggests that our better approach is going with a mismatched unrelated donor transplant. If death because of the treatment is the most concerning factor, that favors moving on with Skysona. And what do I recommend when asked? I recommend gene therapy between those two things. And what we do is we try to do gene therapy in a way to minimize the risk to the best of our knowledge of developing MDS or leukemia, right? So that means, as was talked about earlier, going with the conditioning that was used in ALD 102, busulfan and cyclophosphamide, trying to avoid growth factor exposure if at all possible, and then following very closely like we would for those patients who genetically have an increased risk of MDS or leukemia, because if we see the onset of MDS, we know if we can catch it early, our outcomes with fixing it with bone marrow transplant are going to be better. All right, thank you guys so much for your time, and I'd love to have a dialogue and answer any questions that you have.
Thank you so much for that presentation. I had a question, and I'm not sure if this would be for you or for Rich, but when we talk about the vector and how that's probably the biggest issue and having to do clinical trials again, is there a possibility of adjusting or replacing the vector and not having to do clinical trials again because we're making the treatment better, or is that just a necessary part of perfecting the treatment that exists?
I think I can answer this, and happy to have Rich's opinion as well, but I think there is essentially no chance that one could do that without having a new clinical trial. I think there may be the ability to limit the number of patients that would be needed in a new clinical trial, given that there is proof of efficacy from prior studies as well. So you might not have to meet the same size requirements for it, but I don't think that there is any way to do this without a new clinical trial, particularly because of the concern that the thing that you're building upon had this risk of MDS and leukemia.
I completely agree with Tim here, and I think the other thing is, the obvious thing is to change the promoter, right? Change the promoter, maybe something that's not as widespread in use. The problem is we don't know if that's going to work yet, right? So that will take a little bit more time to work than just being able to study it. And the other thing is, if you think about it, in 102, it took 7 years for the first case of MDS to occur. And so there needs to be that time of follow-up as well to follow, and the number of patients too. I was on the line with somebody who's developing a gene therapy for a type of immune deficiency in the Netherlands a couple weeks ago. And they said to me, "Oh, we're not worried about any MDS anymore because we had 5 patients." I said, "How long have they been treated for?" "Oh, the longest one was about 18 months. And I thought, "No, you have no idea," right? And so I think that's just something, it will take time and will take numbers, unfortunately.
All right, thank you.